10 megahertz probe, 20 megahertz probe, and the 50 megahertz probe. We start off, this is just an overview of that ultrasound and what we have learned, where do we stand, and what is the future. We start off with the vitreous echoes, and these are, as I tell always in any session, only by vitreous echoes it's difficult to say whether it is infection or hemorrhage. These are vitreous floaters. That is more like to be inflammatory echoes because there is thickening of the chorioretinal layer, and we can grade the inflammation in terms of vitritis, endophthalmitis, and panophthalmitis. There is classical asteroid hyalosis where the echoes are of very bright intensity and high reflectivity, more in the center of the vitreous cavity, with the echo poor vitreous in front of it. And that's classical vitreous hemorrhage, more in the center, and inflammation is more at the periphery. And that's how we grade inflammation. That's endophthalmitis, and that's panophthalmitis. When there is fluid in the Tenon space, we call it panophthalmitis. Now, what type of infection is there is difficult to say from ultrasound, but this is a classic exam case where there is fluid in the Tenon space. There is enlargement of the optic nerve, more thickening of the chorioretinal layer at the posterior pole, less at the periphery. This is classical posterior scleritis. If you are exam going, this will come in the exams for sure. Now, vitreous hemorrhage at the earlier stage, it is just seen as few echoes. Then it gets coalesced to form a mass-like lesion and form multiple membranes. Where those membranes are attached to the vitreous cavity, those are sites of tractional detachment. And here you can see that the macula has been pulled up because of the hemorrhage, and this should be alerted to the vitreoretinal surgeon to plan the treatment accordingly. Again, I brought this slide really to fill out that this is vitreous hemorrhage and this is inflammation. Can we differentiate only based on ultrasound? No. It's always a clinical diagnosis. Ultrasound just helps us to grade the echoes, and it does not tell us whether it is hemorrhage or inflammation. Coming to membranes in the vitreous cavity, this is a retinal detachment, and these three are vitreous detachment. Amongst all the criteria, the most important criteria is the echogenicity of the membrane. A uniform, thick membrane is an RD. An irregular, undulating membrane is a PVD. If that's the most important way of differentiating an RD from a PVD, apart from the movement and the A-scan reflectivity. So, you're differentiating between RD and a PVD, that's a retinal detachment with a vitreous detachment, that is PVD. And again, reiterate, it is uniform, thick membrane. Thin undulating membrane is a PVD. There are no after movements in an RD unless it's very early. There are few after movements in a PVD. And the reflectivity is 80 to 100% in an RD and less in a PVD. Now, coming to few cases which are a little tricky from an ultrasound point of view. When we are dealing with post-operative retinal detachments, this is a scleral buckle. You see a detachment from the optic disc to a buckle. That's a classical vitreous skirt, which is seen always after a vitrectomy patient. It should not be confused for a retinal detachment. And you get a small, sometimes elevated retina at the periphery or at the posterior pole in a post-operative status. And these are elevated retina because of serous fluid collection, should not be confused with the detachment. You need to follow this up. A lot of times this settles down on its own. And the vitreous hemorrhage which occurs in a vitrectomized patient, most important is to increase the gains. If you do it at normal gains, you may miss out on a vitreous hemorrhage because there is no gel. The echogenicities are very, very low. Coming to another tricky case is in ultrasound. When we deal with leukocoria, when we see a membrane at the posterior pole, the differential diagnosis which comes obviously to us is whether this is a PHPV or a closed funnel retinal detachment. Now, if you see in a PHPV, there is more thickening of the membrane at the posterior pole and has a thin attachment anteriorly at the posterior capsule. It's a very pinpoint attachment. But whereas if there's a closed funnel detachment, it is a thin attachment at the posterior pole and it fans out as we go anteriorly. So that helps us to differentiate a PHPV from a closed funnel detachment. Obviously, the treatment is different, prognosis is different. Now you can have another tricky situation where a clinical two differential diagnoses on ultrasound and same clinical picture. If you have a completely opacified anterior segment, like the cornea is opacified, anterior lens is gone, you don't know what's happening. The PL is query, PL is faulty, we don't know. You have two situations here. If you look at this side on the right side slide, you can see a thin Y-shaped black hypoechoic membrane and echogenic areas in the subretinal space. Now, usually the subretinal space is hypoechoic, but when there is chronic RD, the retina becomes atrophic and thin, and it becomes black, and the subretinal fluid starts getting cholesterol deposits inside, and it becomes more echogenic. So this is a closed funnel, long-standing RD, nothing much can be done, whereas here this is just plain organized vitreous hemorrhage. So you have two clinical, two ultrasound diagnoses and same clinical situation. Now again, look at these two pictures. They look almost similar to each other. They again are opposed a very bad complication of a cataract surgery. You have completely opacified vitreous. If you look at the slide on the right side, there are complete vitreous echoes right up to the optic disc area, occupying the entire vitreous cavity. Whereas if you look on the left side, you can see those echoes here, but you can see a clear triangular space right in front of the optic disc. This is spontaneous expulsive hemorrhage, and this is completely opacified vitreous. Two different clinical situations and a different diagnosis, but the same clinical picture. Now, coming to mass lesions in the vitreous cavity, you have retinoblastoma, which is the most commonest thing in the younger age group. Calcification is thought to be the diagnostic point, but only 50% of the retinoblastomas calcify. So you have to look for calcifications in those lesions, and probably a CT might help, but playing around with the gains of the machine can highlight the calcification much better than what you do otherwise. So in a retinoblastoma case, you reduce the gains and highlight the calcification, as you would do in this case. Now if you look at this patient here, there's probably some shadowing. We are not very sure. It's a mass lesion with few echoes inside. When I reduce the gains here or a different amplification, I can highlight the calcifications very well. And there are micro calcifications. They need to be seen with very reduced gains. Again, the differential diagnosis of leukocoria, apart from the PHPV that we saw earlier, this is classical PHPV. That is the ROP, Coats disease, sorry, and that's the ROP. Again, in ROP, you don't see echogenicity in a subretinal space. In Coats disease, you see a lot of echogenicity in a subretinal space because of cholesterol deposits. Coming to tumors in the elder age group, melanoma is probably the only tumor which can be diagnosed with certainty on ultrasound because it has a very peculiar picture. If you cut a melanoma on a histopathology slide, all the melanin cells are uniformly distributed. And therefore, it is the only tumor which is uniform, echogenic, and of a low intensity all throughout. Now, that is the hallmark of a melanoma. And therefore, you get the classical sign on A scan. It's an anterior spike and the cascading reflectivity, because there are no interfaces inside. From an ultrasound point, if you have interfaces between the two echoes, the spikes will be high. If there are no interfaces, the spikes will be low. That's how the A scan typical picture is, cascading reflectivity. Now, coming to other differential diagnosis of a melanoma in more of an Indian settings, hemangioma is actually a diagnosis which can be made with certainty on ultrasound if we can pick up a small echogenic phlebolith over the surface. Now, if you see a small echogenic area here, if you sorry, you want to highlight it very well, you have to again decrease the gains, and you can see a bright speck over here. All the echoes have subsided, and that's a classical way of diagnosing a hemangioma. Again, the same, sometimes suprachoroidal hemorrhages, the choroidal membrane may not be highlighted very well. You need to amplify and use the machine very well to highlight the choroidal membrane, and so this is suprachoroidal hemorrhage and not a choroidal mass lesion. I had a patient who was an 80-year-old gentleman, army man, who had sudden loss of vision on the one side, and there was nothing seen. It was just a red echo inside glow inside the eye. If you see this ultrasound, it definitely looks like a choroidal mass. You know, your bumpy lesion here in an 80-year-old, I thought probably it is a metastatic lesion, doesn't look like a melanoma. This gentleman just vanished. He said, I don't want to do anything in the eye, and probably came after 6 months or 8 months, I don't remember. and he said that, okay, let's get an ultrasound done. So he came to me for a follow-up ultrasound. Now you see here, this mass lesion which was seen completely here, you start seeing two bumps here, and the optic disc area is now becoming very clear. So this was suprachoroidal hemorrhage, which has started resolving here. That was an associated some amount of vitreous hemorrhage, which was not, which looked like a mass on the earlier scan. And then he again vanished and said, I don't want to do anything. I'm absolutely fine. Came after 1 year. You see the suprachoroidals have already gone. It's developed as the vitreous hemorrhage with a PVD attached to here. So at this stage, it was a difficult thing to diagnose. This follow-up shows us. So suprachoroidal hemorrhage is probably should be on the mind whenever we see a choroidal mass lesion, especially in Indian settings, because we don't see melanomas that very often. Ultrasound in trauma is a very tricky thing. Whenever you see a patient on first day of trauma, you should be very careful in making a bold diagnosis, because over a period of time, the vitreous resolves and you see a lot of changes. You see these two patients on the first day of trauma, I saw this is as a vitreous hemorrhage and there was no RD. That's what I was reported out of. And after 10 to 15 days, he came for a follow-up. The hemorrhage has got resolved and there is an RD which is developing. So if the patient goes to a VR surgeon, is operated after a 10 to 15 days with a report which was done 10 days prior, you will be on a surprise at the operation table. Again, here I thought that this was a retinal detachment with subretinal hemorrhage over here. But over 10 to 15 days when this patient came, all the hemorrhage, subretinal hemorrhage is resolved and it's just a PVD. So you need to do an ultrasound prior to any surgical procedure if the ultrasound is done some days back. Intraocular foreign body, again as I told you, you need to play around with the gains to highlight the foreign body. You look here, this is organized hemorrhage with a dense echo inside. I am not too sure it was a foreign body, but I had done an X-ray and I could see a foreign body, therefore I was looking out for one. So then again, this is called as the log amplification in my machine. There are different names in different machines. If you do that, you can highlight the foreign body very well. All the echoes are subsided. Shadowing may not always be present. The same principle can be used in the orbit, because the foreign body gets masked with the orbital fat, and there is fluid here around this foreign body which can be highlighted well with the S7 amplification. Lastly, before I close, I want to introduce 20 megahertz ultrasound. We do not normally use the 20 megahertz probe in routine ultrasounds, but it is helpful in certain conditions where you can highlight certain pathologies very well. You look at these two images from a 10 megahertz probe and the same as to be looked on the 20 megahertz probe. Now, there hardly, I mean, this is an organized hemorrhage with PVD. It can be seen very well over here, a suprachoroidal, which can be seen on 10 also very well. But the usefulness of 20 megahertz probe is more for the posterior capsule, for differentiating small elevated lesions over the retina. As you see here, we have two patients over here, where I can see just a minimal elevation of the retina at the periphery. I am not too sure whether I am dealing with a mass or not. And again, a small elevated lesion. This both are seen on 10 megahertz, difficult to differentiate. I put the same patient here on a 20 megahertz probe. I can see that this is just an elevated retina with some amount of subretinal fluid. We can hang on, wait for some time. It will probably get resolved on its own. Where this lesion still remains solid, there is no fluid over here. This fellow needs to be followed up, probably a development of an early melanoma. So that's how the 20 megahertz helps. On the optic disc area, it helps us to pick up very, very early optic disc cupping. This may be missed out on the 10 megahertz probe. You can see an optic disc drusen, whereas on a 10 megahertz, there can be hardly anything to be seen very well. Now, 20 megahertz probe I used to use in an era before the advent of the OCT. And then when the OCT came, I started comparing with that. But you can compare the 20 megahertz probe with the OCT here. We had a large PED which is seen on the 20 megahertz. But of course, there is no way that you can say that this is a replacement for OCT. OCT obviously shows much, much more than that. But if you, again you see cystoid macular edema, which can be highlighted on a 20 megahertz probe. Traction over the macula, which is seen on OCT, can be seen with the 20 megahertz probe also well, but this is all gross. OCT is much, much superior. I'm not saying that it is a replacement for that. Again, a small tractional elevation. If you highlight the 20 megahertz probe, you can see very well. So, 20 megahertz probe can be used as what I call as opaque media OCT. What do you do when you have hemorrhages like this? If you want to see the macula and you want to give a prognosis to the patient prior to a vitrectomy surgery, your macular status is extremely important. So you have vitreous hemorrhage, and if you have elevated maculas like this or a traction on the macula, you can alert the vitreoretinal surgeon, or if you're doing an ultrasound yourself, you know that the macula is elevated, and probably it will, you have to give a guarded prognosis to the patient. In pediatric cases, 20 megahertz is extremely useful. I had a patient who had leukocoria, small child for about 6 months old. On the 10 megahertz, you can hardly make out anything. Probably there is something behind the posterior capsule. I am not too sure. But on a 20 megahertz probe, I could see a thin membrane attached to the posterior capsule, going only up to the mid-vitreous. This was anterior PHPV highlighted on a 20 megahertz probe, not seen on a 10. Cystocircus, again, you can see that a 10 mega, this was a cystocircus in the ciliary body, where a 10 megahertz probably is too anterior. For UBM, it is too posterior. On a 20 megahertz, you can highlight the cystocircus very well. Subluxated lens with zonules can be seen very well on a 20 megahertz probe. The posterior capsule can also be highlighted very well. You have a posterior polar cataract. This is the capsule is intact. That is the posterior lenticonus over here. And before I end the last slide for a 20 megahertz probe, it's a very interesting case really. I had a couple, which was both of them were homeopaths. They came home on a motorcycle, and the husband said that I had some irritation in the eye. So the wife said that you don't need to go to an ophthalmologist, I am here. So she looked at her with a torch and saw a small speck on the cornea. Here you just have a small foreign body, I'll just remove it like that. So she took a 20 cc syringe, filled it up with saline, and said, I'll flush out the foreign body inside. And then when they put the needle there, the needle came out like a bullet from the, while pushing from the syringe. The needle went through the cornea. You can see a clear corneal cut over here, through the anterior capsule, through the lens matter, through the posterior capsule. That's a break in the posterior capsule, and the lens matter into the anterior vitreous. So these are all highlighted well on 20 megahertz probe. Patient underwent a vitrectomy and everything, and he is now fine. So in perspective, a high resolution ophthalmic probe is very useful. Probably not in all clinical situations, but in some it helps us to highlight certain areas better. If you have a good clinical history and maximum examination findings, it helps us to differentiate a lot of membranes and echoes in the vitreous cavity, and helps us to differentiate different patterns. Do not jump to conclusion, especially in trauma. That's the message I want to give. Do not make bold diagnoses on day one of trauma. Everything picture changes in 10-15 days, and always do an ultrasound prior to doing a final vitrectomy surgery. And follow-up sometimes helps us to give us more clear picture of getting on. And good utilization of the machine. There are lots of amplification factors. There are lots of gain settings which are there in the machines. If you can just play around with them like a toy, how you do on a mobile phone, you can probably make much better diagnosis and much helpful in clinical picture. Thank you very much.